Hi, we're from the Acute Care team, and today we're bringing you the Respiratory Webinar. Today's objectives are to go through the anatomy and physiology, respiratory assessment, respiratory management, oxygen titration, and touch upon mechanical ventilation. So why do we need a respiratory system? The cells of the human body require a constant stream of oxygen to stay alive. The respiratory system provides oxygen to the body's cells while removing carbon dioxide, a waste product which can be lethal if allowed to accumulate. There are three major parts of the respiratory system: the airway, the lungs, and the muscles of respiration. The airway, which includes the nose, mouth, pharynx, larynx, trachea, bronchi, and bronchioles, carry air between the lungs and the body's exterior. The lungs act as the functional units of the respiratory system by passing oxygen into the body and carbon dioxide out of the body. Finally, the muscles of respiration, including the diaphragm, intercostal muscles, work together to act as a pump, pushing air into and out of the lungs during breathing. And now we're going to explore the anatomy and physiology in further depth. So we're going to start off with the nose and nasal cavity. These form the main external opening for the respiratory system and are the first section of the body's airway, which is the respiratory tract through which air moves. The nose is a structure of the face made of cartilage, bone, muscle, and skin. And this supports the anterior portion of the nasal cavity. The nasal cavity is a hollow space within the nose and skull that is lined with hairs and mucous membrane. The function of the nasal cavity is to warm, moisturize, and filter the air entering the body before it reaches the lungs. Hair and mucus lining in the nasal cavity helps to trap dust, mold, pollen, and other environmental contaminants before they can reach the inner portions of the body. Air exiting the body through the nose returns moisture and heat to the nasal cavity before being exhaled into the environment. Next, we'll move on to the mouth, also known as the oral cavity. It's the secondary external opening for the respiratory tract. Most normal breathing takes place through the nasal cavity, but the oral cavity can be used to supplement or replace the nasal cavity's functions when needed. Because the pathway of air entering the body from the mouth is shorter than the pathway of air entering from the nose, the mouth does not warm and moisturize the air entering the lungs as well as the nose performs this function. The mouth also lacks the hairs and sticky mucus that filter the air passing through the nasal cavity. One advantage of breathing through the mouth is that it's a shorter distance and larger diameter, which means more air can enter the body quickly. The pharynx, also known as the throat, is the muscular funnel that extends from the posterior end of the nasal cavity to the superior end of the esophagus and the larynx. The pharynx is divided into three regions: the nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is the superior region of the pharynx found in the posterior of the nasal cavity. Inhaled air from the nasal cavity passes on to the nasopharynx and descends through the oropharynx, located at the posterior of the oral cavity. Air inhaled through the oral cavity enters the pharynx at the oropharynx. The inhaled air then descends to the laryngopharynx, where it's diverted to the opening of the larynx by the epiglottis. The epiglottis is a flap of elastic cartilage that acts as a switch between the trachea and esophagus. Because the pharynx is also used to swallow food, the epiglottis ensures that air passes into the trachea by covering the opening of the epiglottis. During the process of swallowing, the epiglottis moves closer to the trachea to ensure that food enters the esophagus and prevents choking. The larynx, also known as the voice box, is a short section of airway that connects the laryngopharynx and the trachea. The larynx is located at the anterior portion of the neck, just inferior to the hyoid bone and superior to the trachea. Several cartilage structures make up the larynx and give it its structure. The epiglottis is one of the cartilage pieces of the larynx and serves as the cover of the larynx during swallowing. Inferior to the epiglottis is the thyroid cartilage, which is often referred to as the Adam's apple and is most commonly enlarged and visible in adult males. The thyroid holds open the anterior end of the larynx and protects the vocal folds. Inferior to the thyroid cartilage is the ring-shaped cricoid cartilage, which holds the larynx open and supports the posterior end. In addition to the cartilage, the larynx contains special structures known as vocal folds, which allows the body to produce the sound of speech and singing. The vocal folds are folds of mucous membrane that vibrate to produce vocal sounds. The tension and vibration speed of the vocal folds can be changed to change the pitch that they produce. The trachea is a 5-inch long tube made of C-shaped hyaline cartilage rings lined with pseudo-satrified ciliated columnar epithelium. The trachea connects the larynx to the bronchi and allows air to pass through the neck and into the thorax. The rings of cartilage making up the trachea allow it to remain open to the air at all times. The open end of the cartilage rings faces posteriorly towards the esophagus, allowing the esophagus to expand into the space occupied by the trachea to accommodate masses of food moving through the esophagus. The main function of the trachea is to provide a clear airway for air to enter and exit the lungs. In addition, the epithelium lining that the trachea produces mucus that traps dust and other contaminants and prevents it from reaching the lungs. Cilia on the surface of the epithelial cells move the mucus towards the pharynx, where it can be swallowed and digested in the gastrointestinal tract. Now moving on to the bronchi and bronchioles. At the inferior end of the trachea, the airway splits into left and right branches known as the primary bronchi. The left and right bronchi run into each lung before branching off to smaller secondary bronchi. The secondary bronchi carry air into the lobes of the lungs, 2 in the left lung and 3 in the right lung. The secondary bronchi split into many smaller tertiary bronchi within each lobe. The tertiary bronchi split into many smaller bronchioles that spread throughout the lungs. Each bronchiole further split into many smaller branches, less than 1 millimeter in diameter, called terminal bronchioles. Finally, millions of tiny terminal bronchioles conduct air into the alveoli of the lungs. As the airway splits into tree-like branches of the bronchi and bronchioles, the structure of the walls in the airway begin to change. The primary bronchi contain many C-shaped cartilage rings that firmly hold open the airway to give the bronchi cross-sectional shape like a flattened circle, or such as the letter D. As the bronchi branch into the secondary and tertiary bronchi, the cartilage becomes more widely spaced and more smooth muscle and elastin protein is found in the walls. The bronchioles differ from the structure of the bronchi as they do not contain any cartilage at all. The presence of smooth muscle and elastin allow the smaller bronchi and bronchioles to be more flexible and contractile. The main function of the bronchi and bronchioles is to carry air from the trachea into the lungs. Smooth muscle tissue in their walls helps to regulate the airflow into the lungs. With greater volumes of air required by the body, such as during exercise, the smooth muscle relaxes to dilate the bronchi and bronchioles. The dilated airway provides less resistance to airflow and allows more air to pass into and out of the lungs. Smooth muscle fibers are able to contract during rest to prevent hyperventilation. The bronchi and bronchioles also use mucus and cilia in their epithelial lining to trap and move dust and other contaminants away from the lungs. The lungs are a pair of large, spongy organs found in the thorax, lateral to the heart and superior to the diaphragm. Each lung is surrounded by a pleural membrane that provides the lung with space to expand, as well as negative pressure space relative to the body's exterior. The negative pressure allows the lungs to passively fill with air as they relax. The left and right lungs are slightly different in size and shape due to the heart pointing to the left side of the body. The left lung is therefore slightly smaller than the right lung and is made up of 2 lobes, while the right lung is made up of 3. The interior of the lungs is made up of spongy tissues containing many capillaries and around 30 million tiny air sacs known as alveoli. The alveoli are cup-shaped structures found at the end of the terminal bronchioles surrounded by capillaries. The alveoli are lined with thin, simple squamous epithelium that allows the air entering the alveoli to exchange its gases while the blood passing through the capillaries. Surrounding the lungs are sets of muscles that are able to cause air to be inhaled or exhaled from the lungs. The principal muscle used for respiration in the body is the diaphragm, a thin sheet of skeletal muscle that forms the floor of the thorax. When the diaphragm contracts, it moves inferiorly a few inches to the abdominal cavity, expanding the space between the thoracic cavity and pulling air into the lungs. Relaxation of the diaphragm allows the air to flow back out of the lungs during exhalation. Between the ribs, there are many small intercostal muscles that assist the diaphragm with expanding and compressing the lungs. These muscles are divided into 2 groups, the internal intercostal muscles and the external intercostal muscles. The internal intercostal muscles are a deeper set of muscles that depress the ribs to compress the thoracic cavity and force air to be exhaled from the lungs. The external intercostals are found superficial to the internal intercostals and function to elevate the ribs, expanding the volume of thoracic cavity, causing air to be inhaled to the lungs. So pulmonary ventilation is the process of moving air into and out of the lungs to facilitate gas exchange. The respiratory system uses both a negative pressure system and the contraction of muscles to achieve pulmonary ventilation. The negative pressure system of the respiratory system involves the establishment of a negative pressure gradient between the alveoli and the external atmosphere. The pleural membrane seals the lungs and maintains the lungs at a pressure slightly below that of the atmosphere while the lungs are at rest. This results in the air following the pressure gradient and passively filling the lungs at rest. As the lungs fill with air, the pressure within the lungs rises until it matches atmospheric pressure. At this point, more air can be inhaled by the contraction of the diaphragm and the external intercostal muscles. This increases the volume of the thorax and reducing the pressure of the lungs below that of the atmosphere again. To exhale air, the diaphragm and external intercostal muscles relax while the internal intercostal muscles contract to reduce the volume of the thorax and increase the pressure within the thoracic cavity. The pressure gradient is now reversed, and this results in the exhalation of air until the pressure rises inside the lungs and outside the body are equal. At this point, the elastic nature of the lungs causes them to recoil back to their resting volume, restoring this negative pressure gradient present during inhalation. So now we're going to tie the anatomy together and explore how we respire, and that's through external respiration and internal respiration. So external respiration is the exchange of gases between the air filling the alveoli and the blood in the capillaries surrounding the wall of the alveoli. Air entering the lungs from the atmosphere has a higher partial pressure of oxygen and a lower partial pressure of carbon dioxide than the blood does in the capillaries. The difference in the partial pressures causes the gas to diffuse passively along their pressure gradients from high to low pressure through simple squamous epithelium lining of the alveoli. The net result of external respiration is the movement of oxygen from the air into the blood and the movement of carbon dioxide from the blood into the air. The oxygen can then be transported to the body's tissues while carbon dioxide is released into the atmosphere during exhalation. Now, internal respiration is the exchange of gases between the blood in the capillaries and the tissues of the body. Capillary blood has a higher partial pressure of oxygen and a low partial pressure of carbon dioxide in the tissues which it passes. The difference in these partial pressures lead to the diffusion of gases along their pressure gradients from high to low pressure through the endothelium lining of the capillaries. The net result of this is the internal respiration is the diffusion of oxygen into the tissues and diffusion of carbon dioxide into the blood. So the transportation of gases. So the two major respiratory gases are obviously oxygen and carbon dioxide, and these are transported through the body in the blood. The blood plasma has the ability to transport some dissolved oxygen and carbon dioxide, but most of the gases are transported in the blood are bonded to transport molecules. Hemoglobin is an important transport molecule found in the red blood cells, and it carries almost 99% of the oxygen in the blood. Hemoglobin can also carry a small amount of carbon dioxide from the tissues back to the lungs. However, the vast majority of carbon dioxide is carried in the plasma as a bicarbonate ion. When the partial pressure of carbon dioxide is high in the tissues, the enzyme carbonic anhydrase catalyzes a reaction between carbon dioxide and water to form this carbonic acid. Carbonic acid then dissociates into hydrogen ion and bicarbonate ion. When the partial pressure of carbon dioxide is low in the lungs, the reactions reverse and the carbon dioxide is liberated into the lungs to be exhaled. So under normal resting conditions, the body maintains a quiet breathing rate and depth called eupnea. Eupnea is maintained until the body's demand for oxygen and production of carbon dioxide rises due to greater exertion. Autonomic chemoreceptors in the body monitor the partial pressures of oxygen and carbon dioxide in the blood, and then send signals to the respiratory center of the brainstem. The respiratory center then adjusts the rate and depth of breathing to return the blood to its normal level of gas partial pressures. So now we're going to look at when the body struggles with this homeostatic control, such as when a patient is in respiratory failure. Now, respiratory failure comes as type 1 and type 2. So type 1 is associated with damage to the lung tissue, which prevents adequate oxygenation of the blood. However, the remaining normal lung is still sufficient to excrete this carbon dioxide. This results in low oxygen and normal or low carbon dioxide levels. The arterial oxygen pressure is less than 8 kilopascals with normal or low arterial carbon dioxide pressure. So type 2 occurs when alveolar ventilation is insufficient to excrete this carbon dioxide that's being produced. Inadequate ventilation is due to reduced ventilatory effort or inability to overcome the increased resistance to ventilation. It affects the lungs as a whole, and therefore carbon dioxide accumulates, presenting with a PaO2 of less than 8 kilopascals, or normal, with a hypercapnia, a PaCO2 of over 6 kilopascals. So there's some common causes for type 1 respiratory failure, and these include pulmonary edema, pneumonia, COPD, asthma, acute respiratory distress syndrome, chronic pulmonary fibrosis, pneumothorax, pulmonary embolism or PE, pulmonary hypertension. Type 2 respiratory failure is commonly caused by COPD, but may also be caused by chest wall deformities, respiratory muscle weakness, and central nervous system depression. This CNS depression is associated with reduced respiratory drive and is often a side effect of sedatives, strong opioids. It might also be caused by conditions such as severe asthma, myasthenia gravis, muscle disorders, and obesity. So what are some of the signs and symptoms of respiratory failure? So people with a high carbon dioxide level might experience rapid breathing, confusion. People with low oxygen levels might experience the inability to breathe, a bluish coloration in the skin, fingertips or lips, and people with an acute failure of the lungs and low oxygen levels may experience restlessness, anxiety, sleepiness, loss of consciousness, rapid and shallow breathing, irregular heartbeats or arrhythmias, and profuse sweat. So the way we perform an assessment on these patients is to look, listen, and feel. So to look, we'd look at peripheral cyanosis. Are they shutting down peripherally to perfuse the vital organs? Do they have this central cyanosis? Now, this can be quite a late sign of cardiovascular compromise as the body is struggling to perfuse. Are they using accessory muscles? So is the patient working quite hard to breathe or having to compensate? Look at the rate. So measure how fast they're breathing, just as you would in normal observations. So look at your patient's rhythm. So what's the depth of the breathing? Is it shallow? Is it deep? Look at the symmetry of the chest. So is the chest having equal expansion, or is one side not moving? This could be potentially a pneumothorax, or look for any evidence of flail chest post-trauma. Look at your patient's cough strength. Is it effective? Is it ineffective to expectorate? Could the patient be silently aspirating? So when we're listening for a patient, we need to listen for added sounds. So what extra sounds can be heard? So these can be through crackles, which are often an intermittent sound that is most pronounced during inspiration. This sound can be quite clunky, rattling, crackling, clinking, or popping, and occurs when smaller airways are opening suddenly during inspiration. Crackles can be further defined as moist or dry, fine or coarse, with fine crackles thought to be related more to smaller airway disease, and coarse crackles with larger airway conditions. Crackles are often related to the buildup of fluid in the alveoli, and some of these causes might include pulmonary edema, right-sided heart failure, pneumonia, and pulmonary fibrosis. Now, a wheeze can be described as a high-pitched whistling sound, usually more pronounced on expiration. So the common causes of this are asthma, COPD, bronchitis, or a foreign body obstruction. A stridor, this is referred to as a high-pitched sound that can be mostly heard during inspiration. Now, a stridor should be addressed urgently as it can indicate a medical emergency. This can be due to an upper or lower obstruction, swelling of the epiglottis, and this is an emergency that might require intubation to protect the patient's airway. Gurgling can be described as fluid bubbling. This is usually caused by fluid gathering around the oropharynx, and this could be due to high levels of secretions, vomiting, or a patient aspirating as they're not effectively swallowing. The patient might require oral suctioning and a nasal pharyngeal airway, which could be considered to aid in this suctioning. You may also notice there's absent sounds, so lack of sounds. So this could be from quiet bases, so a lack of air entry to the base of the lungs, and this could be due to pneumonia, atelectasis, pleural effusion, or heart failure. Or you could have an absence of sounds, so lack of air entry to the lungs, which could be potentially a complete airway obstruction, or if a patient's intubated, their endotracheal tube might be displaced. Finally, we're going to feel. So feel for a tracheal deviation. Now this could be due to trauma, but is also a very late sign of a tension pneumothorax, and the patient is very likely to go into a cardiac arrest without intervention such as a chest drain. Chest wall expansion, so by placing your hands on the patient's rib cage, we can feel the patient's chest expansion. This should feel equal in movement, depth, and rate. If the patient has crackles, you might also feel this in the form of vibrations when they inspire. Also, please ensure that any respiratory observations are taken over the place of a full minute, just to get an accurate assessment. So some of these patients might require some respiratory management. Now, respiratory management can be a multitude of actions to aid a patient's respiratory function and to either treat or help a patient's compensatory mechanisms. So looking at treatment, we've got nebulization. So this can be used to deliver medications such as salbutamol to help with wheezing or asthmatic patients. But a saline nebulizer can also be used to loosen up thick secretions, allowing a patient to cough them up easier and clear the airways. Inhalers are aerosol devices that allow a patient to breathe in medications. Usually, these are a bronchial dilator which help open up the airways. Consider your patient's positioning. So, a patient sitting upright will allow the bases of the lungs to expand, rather than the patient being slumped in the bed. Now, changing your patient's position will also help with postural drainage. So, moving your patient to the left-hand side will help clear the right base of the lung. The patient then might be able to expectorate some of these secretions once it's moved further up the respiratory tract. It's worth considering some deep breathing exercises too. So one of the ways we do this is using intensive spirometry. Now, it's designed to make a patient take deep breaths to open up collapsed alveoli. When a patient performs this, they are aiming to elevate some plastic balls on a device as an indicator to how well they're doing. Post-surgery, these devices are commonly used to help patients who have been laid flat on an operating table for hours and might have some elements of lung collapse or atelectasis. Post doing intensive spirometry, it can also worth seeing if the patient can cough up any secretions they might have. Performing these deep breathing exercises can be beneficial in the recovery of patients with respiratory conditions. It can also be very important to keep your patient motivated to be doing all the things that they should, such as sitting them out of bed every day to prevent chest infections and get their body working a bit more, and also getting some level of exercise by moving around. Keeping them motivated to be actively involved in the treatment can help them feel better emotionally and help in the recovery process. So now we're going to look at the process of escalation of care for patients with a respiratory requirement, and this is going through the different devices that we may use. So first off, we'd start with oxygen therapy. Now, patients on the ward will use various devices and escalate up each device as appropriate to reach target saturations. So firstly, looking at nasal cannula. So it does have its downfalls. It can be quite drying and damage mucosa, causing headaches and irritation. Patients could also be mouth breathers and not fully utilising the therapy as they won't be breathing in the oxygen. Humidified is good as it gives the patient humidification, as normally the air we breathe has some humidity, whereas pure oxygen is quite drying and can be quite damaging to the natural linings. Venturi are used to give controlled levels of oxygen, usually for non-acute patients with COPD. However, these are quite good ways of monitoring a patient's oxygen if it's increasing or decreasing the requirements. And finally, a non-rebreathe mask, which is used in acute situations where a patient's oxygen is low and requires high concentration oxygen to be given. So with patients who are using these devices, there is an order in which we should escalate these devices. So in first instance, they'll have a Venturi on 24%, which is 2 to 4 litres, or they could be on nasal specs 1 litre. Moving up, you have 28%, which is the white Venturi, 4 to 6 litres per minute, or nasal specs 2 litres. Then we have the Venturi 35%, which is the yellow, and that's 8 to 10 litres per minute, or nasal specs 4 litres. Now, 4 litres is the most we can give through nasal specs. Moving further onwards, we have Venturi 40%, which is the red one, and that's between 10 to 12 litres per minute. Or we have a simple face mask, which is 5 to 6 litres per minute. A Venturi 60%, which is green, and that's 15 litres per minute. Or we can have a simple face mask, which is between 7 to 10 litres per minute. Beyond this, we're looking at a reservoir face mask, which is 15 litres oxygen flow. So this is your non-rebreathe mask. And if we're moving on to using the non-rebreathe mask, we need to consider senior medical help urgently. Beyond these devices, we also have other things that we can use, usually in critical care environments or respiratory ward environments. One of these is high flow oxygen, and it can give up to 60 litres per minute, can give 100% oxygen, and it's usually nasal high flow, However, a mask can be fitted if nasal isn't appropriate. Beyond high flow, we can also consider CPAP or giving PEEP. Usually this is given in a critical care environment or on acute respiratory wards. So CPAP stands for Continuous Positive Airway Pressure, and it's a type of positive airway pressure where airflow is introduced into the airways to maintain a continuous positive pressure to constantly stent the airways open, and this is in people who are spontaneously breathing. So positive end expiratory pressure, or PEEP, is the pressure in the alveoli above atmospheric pressure at the end of expiration. Now, CPAP is a way of delivering PEEP, but also maintains a set pressure throughout the respiratory cycle during both inspiration and expiration. The application of CPAP maintains PEEP, and this can decrease atelectasis, increase surface area of alveolus, improves ventilation and perfusion matching, and hence improves oxygenation. So if CPAP isn't enough for this patient and they still have a respiratory requirement, they may need mechanical ventilation. Now, this is one of the highest levels of respiratory support we can actually give. So usually it requires intensive care. The patient will need to be continually monitored for any changes. The patient will also need sedation so that they can tolerate the endotracheal tube for ventilation. The patient might also need additional support for other organs or inotropic support for blood pressure. So today we've gone over anatomy and physiology, respiratory assessment of a patient, the respiratory management of a patient, oxygen titration on wards, and we've gone up to the escalation of mechanical ventilation. I just wanted to say thank you for listening, and we hope this has been helpful.